Thank you, Dr. Preeti. Respected professors, senior consultants, and dear friends, it's really great pleasure for me to be in this wonderful gathering in a post-lunch session organized by Apollo. And I would like the first topic is the day in and day out. Without this, most of the routine OP practice will not get complete. And we are going to see as the day progresses, every physician, surgeon, and gastroenterologist will be experiencing this kind of scenario. It's nothing but your gastroesophageal reflux to take on. So what do you mean by the gastroesophageal reflux? Once if your gastric contents, if it is going to refluxate into your esophagus, that means it's going to happen with the gastroesophageal reflux. As you all know, the prevalence will be more common in European scenarios, will be more than 10 to 14%, but in Indian scenarios it will be around 7% as the day progresses. But there are two common characteristic events. So what is this gastroesophageal reflux? Because every day you'll be having some sort of problems in the GI tract. But when the patient will be attending the gastroenterologist, will be remaining the tip of iceberg, because most of the time they will not be tackling the initial presentation, they will not be managing that, and considering they will be going for any other substitute or medication, they will be tackling the treatment on the own, and followed by once the symptoms get worsened, or once the patient is going to end up with multiple complications, at that point of time, the patient will be seeking by the gastroenterologist. So that's why it still remains the tip of iceberg for us to diagnose this GERD. And routine practices, 44% of the population will be experiencing this in monthly event, and 20% weekly, and around 4 to 7% of the population will be experiencing this daily. So to talk on this gastroesophageal reflux, the main in charge is, as you all know, the basic pathophysiologic mechanism we are not supposed to forget, and next to that, what is the basic clinical presentation, and how are you going to diagnose, and when to initiate patient on treatment, and once you are going to treat, how are you going to approach the patient for a clinical scenario which is responding or not for your treatment. Then what are the various complications you may anticipate, and new investigation, diagnosis, and treatment. And this is what the basic outline of our talk today. And apart from that, the basic pathophysiological mechanism that what we have been discussed is anything which affects your esophagus, anything affects your stomach, that's a predominant area. The impact esophageal layer, there are prolonged stages of salivary function, your salivary enzymes is going to get impaired, and in case if you're going to have a hiatal hernia, and the defense mechanism, if it is not going to be activated, at that point, your transient lower esophageal TLSR, which means your transient lower esophageal relaxation, all those things, if it is not going to maintain, at that point of time, there might be evidence of your reflux to take on. And not only for that, even your pyloric incompetence is another mechanisms to discuss about that. So basic anatomy, because the time is restricted, so I'll be going with the basic outline. So once the four major competence for your lower esophageal sphincter, in case if it is not functioning properly, that's the reason for you to have a reflux. So the distal 3 to 4 centimeter of your esophagus, your crux of diaphragm, as well as your intra-abdominal portion of your esophagus, your angle of face, and your phreno-esophageal ligament. So the main target is we need to maintain a transient esophageal relaxation at a rate of around 3 to 10 seconds. But in case if it is going to be prolonged for more than 40 seconds at the point of time, there might be evidence of this reflux to take on. And the characteristic presentation will be a heartburn, nothing but your pyrosis, you'll be having intestinal pain, nocturnal symptoms, worsening of events, and most of the patient will not be responding to any basic treatment, and at that point the patient will be seeking your opinion with the gastroenterologist. The basic definition, we are not supposed to forget that a classification, what is called as Montreal classification. So basically we need to remember GERD is when your esophagus and trachea will always go to the same innervation. So the macro aspiration will be the commonest presentation. So any patient who is having GERD, they may be having evidence of cough, extra GI manifestation, and other presentation can be there. So why would like the predominant esophageal symptoms as well as your extra esophageal symptoms, that we are not supposed to forget. Reflux is one characteristic, and always the functional event we are not supposed to forget, because most of the patients in a busy schedule, they'll be having a functional event. That is one classical presentation we should not forget. Apart from that, the complications like your stricture, esophagitis, your Barrett, in which the columnar metaplasia of your squamous, which is going to take on, and extra GI manifestations, very common will be your cough as well as laryngitis. That's another presentation. Apart from that, there are various diagnoses. So how to diagnose this GERD? Say GERD, when you want to diagnose, the most characteristic, first you need to take a good history. what is the weight of the patient, anthropometric assessment, what is the nature, what is the diet, all those things, a proper history taking is very, very important before labeling the patient as having only reflux or having any other complications or having any other presentation. But there are so many diagnostic modalities being available in India, but how far we are going to approach, how far it is going to use in a clinical scenario, that's still a question of target when you're going to manage, because there is no single pointer to come from, because even then the ambulatory pH monitoring or 24-hour pH monitoring can be yielding a significant proportion, but even how many centers they are using that in regular practice is still a questionable issue that has to be addressed. But basically, bearing swallow, not much of use. Endoscopy, definitely you can consider, but endoscopy, not. Even if you're going to do an endoscopy, there are two terminologies in your GERD. You are not supposed to forget that. One is your erosive disease and one more is a non-erosive condition. If you are going to do an endoscopy, you are not going to get any findings in endoscopy. What does it mean? Doesn't mean the patient is not having any evidence of reflux. So non-erosive reflux will be around 50 to 60% of the population will be there, and the erosive pathology will be only 10 to 20% or 30% of the population will be having that kind of presentation. So endoscopy doesn't mean it's indicated for all who are all having the alarming presentation. For example, always in gastroenterology, there are major alarming events we are not supposed to forget. If you're having dysphagia or anophagia, weight loss, significant weight loss, if it is going to be more than 5 to 10%, in case if you're having evidence of suspicion of GAP, and you're going to find a mass or stricture anywhere, and once the patient is going for any evidence of further complications like Barrett's, if the vomiting, if it is going to persist, at the point of junction, it's most important we need to look into the patient for endoscopy in the management of GERD. As I discussed, erosive and non-erosive, there are two basic classifications, but one important classification we are not supposed to forget in the esophagitis is your loss stages, which means how far your esophageal severity is going to get affected when you're doing an endoscopy. If you're going to do an endoscopy, most of the time the patient will not be having finding, but there are other presentations in which you can able to look into this kind of scenario, in which if the esophageal lesion, if it is going to be involved for more than 70%, 75% of the circumferential involvement, at the point the patient is going for grade D esophagitis, which means you need to tackle more effectively. Other modalities is your pH monitoring. If you're planning for hypertonia, repair, surgical intervention, fundoplication, and if the reflux is not persisting, if the patient not responding, so you can go for ambulatory pH monitoring, but it's still a cumbersome procedure, and wireless pH capsule is being there, but even then it's be difficult. But one important thing we should not forget when you're going to do this, your DMIST scoring system. If it is going to be more than 14, see, always we need our target when you're going to use a molecule, you need to improve the esophageal pH more than 4. In case if the pH, if it is going to be persistently less than 4, at that point the junction is going to be more and more reflux. So we need to see the number of reflux episodes based upon your DMIST scoring. If it is going to be more than 14.5, that means the patient is having significant reflux. Your acid exposure time to be calculated. If it is going to be more than 6, it is going to be significant for your GERD. And reflux, if it is going to be more than 80%, it's general a significant abnormality is there. There are other modalities like multi-channel, your Bravo capsule, which means your wireless capsule is just going to place just above 5 centimeters from your stomach or junction in your esophagus. You can use that, but these are all the add-on investigations protocol when you're going to see. This is what the basic outline, your endoscopy, your barium, as well as your impedance, your 24-hour ambulatory pH monitoring, as well as your wireless Bravo. These are all the basic things based upon your clinical presentation to whom you are going to subject. It's important. But you should not forget there are so many etiological factors for reflux. One is by acidic reflux, one is by non-acidic reflux, one is by diurnal reflux. So many things are there. You cannot be able to document all those things just like that. So whether it's a non-acidic reflux, at that point of time, your ambulatory pH definitely is going to have a significant potential role to diagnose that. Our main important area for all the physicians not supposed to forget your GERD management. Basically, any management in gastroenterology start with lifestyle modifications. So what is the primary aim to start with lifestyle modification? Always if you're overweight, reduce your weight, cut down your coffee, tea, all fried food, junk food, all those things, the basic things you're not supposed to forget. But apart from that, stopping of alcohol as well as your quitting of smoking, along with basically GERD management will be your NN elevation when you're going to sleep. At least 6 basic. Apart from that, a frequent small meal and avoidance of high carbohydrate based and high lipid based diets you need to restrict, and physical activity is important, but doesn't mean one point various papers they have been reported. Even if you're going to control your weight, even if you're going to control your BMI, doesn't mean your significant reflux improvement will be there, because the diet and lifestyle modification will be checking on only with 10 to 20% in your GERD management protocol, and strongly most of the patients will be going for your pharmacological support to manage a patient with GERD. So this is what the basics. Apart from that, your lifestyle modification and the basic molecules, as you all well remember, frequently like over-the-counter prescription, we have been using your H2 receptor antagonists along with your PPIs. Nowadays, single-dose PPI, dual-dose PPI, we'll be using, apart from prokinetics, another new molecule being there to try. But basically, antacids, how far it is going to be successful, not much of potential role. And you can use your antacid only for the transient response of your symptoms, because it is going to respond only for 1 to 3 hours of duration. It is going to predominantly form a raft mechanism inside your gastric mucosal pockets. Apart from that, so how does it going to respond? And there are multiple adverse events like alkali syndrome based upon your aluminium or magnesium compounds. What are you going to use? Constipation or diarrhea may report with that. So always antacid preparation is not part of much of potential role when you're going to consider management in gastroenterology protocols. But when you're going to look into your H2 receptor, definitely is one of the best of molecules, because as you all remember, even if you're going to put the patient on PPI, the response will not be that adequate. Sometimes the patient will be having some nocturnal acid breakthrough. At that point of time, the PPI high dose, your H2 blockers at high dose will be having a definite potential role to consider. But there are so many H2 blockers being there in the market. But right now, very frequently, your lamphetidine, your ranitidine, all those things being considered. Nowadays, even your new molecules like levetidine being there in the market to try out. But apart from that, so H2 blockers, there are few adverse events, no major adverse events, and interaction with the cardiovascular molecules will be less. Response is going to come down when you're going to use your H2 blockers. This is what the brief outline about that. And your proton pump inhibitors, the master leaders, you should not forget about that. So proton pump, once the patient is having evidence of erosive esophagitis of almost grade C and D, the proton pump is definitely having a potential role. But in grade A and B, H2 blockers, but grade C and D, H2 blockers is still a questionable issue whether it's going to yield the mucosa well or not. So that's an area we need to address. So start with proton pump inhibitors, at least a duration of 4 to 8 weeks of therapy to be given to assess whether the patient is responding. And apart from that, proton pump is going to act upon your parietal cell area, that's hydrogen potassium ATPase blockers, and double dose PPIs definitely is going to be tried. Always you should not forget that lifestyle, your H2 receptors, apart from your PPI lower dose to higher dose, and very important is your prokinetics to augment your lower esophageal sphincter mechanism. And prokinetics, so many molecules are there, and that isopride, levosulfuride. But one important thing to whom you are going to use, whether the patient is having evidence of gastroparesis is there or not, at that point we are going to consider prokinetics, and the dosage of prokinetics, as you are well know, refractory GERD. This is important entity I want to discuss. It means even if your medication, if the patient not responding, doesn't mean the patient may have multiple complications like eosinophilic esophagitis, non-adherence to treatment, other complications, bad malignant changes. So always you need to be very cautious when you're tackling. Around 30 to 40% of the patient may not show a significant response when you're going to manage, even after a duration of 8 weeks. And there are other new molecules I'm mentioning to diagnose about this. Your PCAP, potassium competitive acid blockers like your onaprazole, all those molecules. And always your GI entirety, you should not forget the functional GI events. When you're going to tackle that, you need to use your antidepressant to some extent, SSRI or TCI to whom you are going to use based upon your clinical presentation. Always the functional GI disorders as per your own category. You are not supposed to forget that when you are going to tackle any patient with GI, because diagnosing and tackling is an entirely different approach. This is all the huge list of new molecules. And surgical intervention, if the patient non-responding, severe hyaluronic, persistent reflux, persistent nocturnal symptoms, you can go for surgery. Laparoscopic surgery means fundoplication, various fundoplication. Your Nissens is very characteristic. When you're going to do your 360-degree fundoplication, apart from those, so many other fundoplication procedures, not much in use nowadays. But endoscopy has taken on a clear lead now to brush up the knowledge. Obviously, you're not supposed to forget that endoscopic intervention is very important nowadays, even in the management of the patient has persistent reflux, rather than the patient to subject with any evidence of surgical intervention. So we can go for radiofrequency ablation of your esophageal mucosa, your transferal fundoplication, and your mucosal resection. There are so many other procedures are there to take on. Before concluding, diet, lifestyle, proper assessment of the patient, and diagnosis, lifestyle modifications, and to whom you are going to subject the patient with H2 receptors. Blockers along with PPIs or prokinetics to whom you are going to subject, analyzing the patient, whether the patient is responding or not, whether the patient adhering to the treatment or not. These things is very important if you want to tackle the presentation successfully in management of GERD. Even with all those things, we still face more complication in our routine practices, whether the patient may develop some other presentation. So with this, I'm happy to rest the presentation. Thank you all for patient listening. If any questions there, I will take.
For the benefit of our audience, we like to ask our panelists regarding their views on this subject, and then we'll quickly move on to the next topic. Can I request Dr. Revati to give us her inputs regarding the usage of PPIs, prokinetics, their adverse effects, long-term adverse effects? Are they safe? What does Madam prefer in her clinical practice?
For that, for the gender physician and the gender practitioners, I would like to tell them they should know to differentiate patient coming with heartburn, how to differentiate it from angina and an anxiety disorder. Because angina is an emergency. They should know first to take a detailed history because they can have chest pain. So it is not immediately they should prescribe medication or go for an endoscopy. If it's typical of an angina, chest pain, radiating, a detailed history to be taken and an ECG and a basic echo should be done before planning for endoscopy if patient complains of chest pain.
That's a very valid and well taken point, because you most definitely will not have a mortality due to GRD, but the reverse is not true.
Many of the MI cases coming to the emergency, we say it's just acidity, I took antacids, they come report very late because the delay, because of the lack of awareness to the public, they come late. So the earlier the treatment, better the prognosis. So I think they should educate the patients about the symptoms and make them aware of the angina, chest pain in those patients.
To remember that vagal symptoms can mimic gastro symptoms. So, like Madam says, just to reiterate the same point. So, Dr. Loganathan.
I think I would like to contribute to whatever she has said. I think we had a patient who came with a rectal burning, but his symptoms are more in favor of angina episode only. So I said I will not do endoscopy, and I referred to cardiologist. He did so many tests and then he prescribed, and then he again came back to me again. He said completely normal. The cardiologist evaluated and said everything is normal. I did the endoscopy also. He came again on the fourth day with the typical classical ECG changes. So you can't be misled, but the only thing is we need to be extremely cautious. And fortunately, he came back to me repeatedly. He came to me, so I was able to fix up at least. If it's going to someone else, then I think our name is going. That's what. You don't have anything on this.
Sir, your role, your views regarding PPIs, prokinetics, combinations, when should we stop? This is very important because it's most indiscriminately used. So
it is easier to prescribe a medicine, but it is important to know when to prescribe, what dose to prescribe, and typically you see dyspeptic symptoms day in and day out, and you should know what dose you should start with depending upon the presentation. And what is more important is that should we add prokinetics right in the beginning, or should you add prokinetics in case you don't find response with PPI? Depends upon the hierarchy and the way that your patient presents with. And the last thing is that it is easy to prescribe PPI, but it is very difficult to de-prescribe PPI. As of now, we are all discussing about how to prescribe PPI, but then things are going on all around the world and in India as well, that how to de-prescribe PPI is what is now currently happening. So as much as you know how to prescribe PPI, please also know how to de-prescribe, which is a huge topic which we go in depth. We will not have time for discussion, but I will say that have caution before you prescribe, and do prescribe it only for an adequate period and a prokinetic as needed. Choose a safe prokinetic. Look at the patient's age. Look for, most of the prokinetics do have an effect on dopaminergic system. So look out for Parkinson's symptoms. And and even the earliest, if you find something, stop prescribing these prokinetics. Go for safer ones. That's most important. And after the adequate period is over, please try to de-prescribe and come out of the PPA. Otherwise, the patient becomes PPA dependent.
Regarding one important thing, we at Apollo offer what we call a 24-hour impedance pH monitoring. This is considered the gold standard for the diagnosis of reflux, either its presence or absence. Dr. Sheshadri is actively involved in GI motility at our hospital. I'd like him to give us his idea. What exactly is pH for, in a broad sense, what does the impedance pH offer to the patient? How does it help us diagnose GERD, present or absent in a patient?
Okay. So Dr. Preetish has equal importance in doing the pH studies. So actually, pH, 24-hour ambulatory pH monitoring is just to diagnose say significant gastroesophageal reflux. So in this, we monitor the amount of acidic reflux that happens from the stomach into the esophagus in 24 hours, and that gives us an idea as to the whether the patient has a significant gastroesophageal reflux disease. This is more important when we are deciding on surgery for the patient, or the patient is not responding to the usual medical line of therapy. And before any patient goes for anti-reflux surgery, it is important that we have a definite diagnosis with 24-hour ambulatory pH metry or an impedance study. So typically, as was described, if the acid exposure time is more than 6% in the esophagus, or the overall D-Lister scoring, which is a composite score, is more than 14, we say it's a significant reflux, and the patient is treated with optimized treatment for GERD, and if he's not having recurrent symptoms, then surgery is considered, or other modalities are considered. That is one side of it. So what is impedance? So the pH metry is going to detect only acid reflux. But other contents from the stomach which go into the esophagus can also cause problems like proximal reflux and microaspirations, and causing other problems. So that's where the impedance comes into play. These patients, we can do the test even when the patient is on PPI. You don't have to stop the PPI. We do a 24-hour monitoring of the volume reflux and see whether it's significant or not based on various parameters. And if that is there, again, we are going to say that patient is having a significant gastroesophageal reflux and manage appropriately. So each has a role to play. One important thing you have to notice is for pH study, the patient should be off PPI and prokinetics for at least 5 days to 7 days. But for impedance studies, the study can be